So, good evening once again, dear Chairman, dear Organization Committee, dear colleagues. Thank you very much for the kind invitation. Very happy to be here. And as you heard, we already had a long day, so I would guess you are hungry. So I will try to give my best to keep to be in time. I think we heard a lot about AF today. AF is a disease with a huge incidence. We heard it in the last two presentations. The incidence is increasing eminently in the last years, and also the cost for our healthcare systems, but also for the patients. And this is everywhere in the world like this. And we know we don't have to go too deep into this, just to keep in mind, because we talked about this today several times. This is a disease mainly of the older population. So most of AF patients are over 70, over 80 years old. But we still have a lot of patients with atrial fibrillation between 60 and 70, and even younger patients. And these are the patients we have to focus on. We have to try to find a way to treat these patients adequately. Dear colleagues, let's think together. What is the rationale or the best way to treat a patient with paroxysmal atrial fibrillation? I heard that most of you are cardiologists, and many interventional cardiologists and many referring physicians. So just consider patient with paroxysmal atrial fibrillation, not too old, maybe 45 years old, completely healthy, but he's symptomatic. If you ask me, I would refer him for catheter ablation. What would you do? I would guess maybe the same, maybe you would give amiodarone, okay? So the drug, I heard flecainide is not ubiquitary available here, so you would give drugs. We have new EC guidelines, and the guidelines are that what we should follow. So what do the guidelines say? The guidelines clearly say consider patient choice at first. Either go for catheter ablation or go for the antiarrhythmic therapy. The new thing in the recent guidelines is that it has a class 2A indication for paroxysmal atrial fibrillation. And the very new, and this is really something fundamental new in the last, which happened in the last, was implemented in the last guidelines. We have a class 1 indication after failed therapy. So, and I think this should be, and this is based on a lot of evidence. We should treat these patients adequately. These are our guidelines. So, we had paroxysmal atrial fibrillation. These are the patients we have to target mainly on. Persistent AF, if they do not have to, we heard about in the first presentation about the risk factors. If they do not have too many risk factors, these patients will also have a beneficial effect. They will profit from a rhythm control. Permanent AF, I wouldn't touch interventionally, just straight control. And what about patients with heart failure? I think this is all in India a huge problem. Patients with heart failure. Look into the guidelines. They say antiarrhythmic drugs or class 1 indication for catheter ablation. These patients, we had the CAST Life trial, which has been published in the New England Journal 3 years ago, I'm sorry. And this trial showed a tremendous benefit for the patients once they get sinus rhythm back. What should we do? catheter ablation. You can do a lot of things in the left atria, but the guidelines are very clear. Once you go to the left atrium, just isolate the PVs and don't do anything else. This is what the guidelines say. But what is the reality in the world? The reality is, as we discussed today, 40% of the patients are asymptomatic. We have symptomatic patients. And how many patients are really treated annually? 4% by catheter ablation. This has different reasons. One reason is, we heard about that, these are complex procedures. Patients are afraid. Referring physicians maybe do not know too much sometimes about these procedures. So there are a lot of different issues. However, if you do it in a correct way, these patients will have a good effect on that. So we heard about that. In most of the patients, the trigger for atrial fibrillation comes out of the left atrium. Just please have a look on this picture, on these two pictures. This is the left atrium. You have a view from posterior, from the back to the left atrium. You see here the septal pulmonary veins. They are cut off in this picture, but however, here it's not cut off, right superior, right inferior. So it's septal pulmonary veins, lateral pulmonary veins. In the back, you will see the left atrial appendage, and here would be the mitral annulus. So, and within these pulmonary veins, there are the triggers. This is what we heard in the previous presentation, where Deepan Shah and Professor Heiseguer from Bordeaux find out if you isolate the veins, these patients will have a great, tremendous effect on getting sinus rhythm. So these are the triggers which are perpetuate and initiate and perpetuate atrial fibrillation. So if we talk about atrial fibrillation, I make this one short. If we talk about atrial fibrillation and ablation, we have to know, you have to know how the recurrence rate are. Because it's very easy. Your patient will ask you, if you want to send him for ablation, your patient will ask you, okay, doctor, what do you think? Will I get AF back or not? And your answer is then, 46%. This sounds horrible. This is not the answer. The answer is, in the long-term follow-up, 20% of the patients might have a recurrence. So the key message is, if you want to go on the track for catheter ablation, cryo, RF, the patient has to know that you potentially need more than one ablation procedure, possibly, and statistically, it's 1.5. So 1 to 2 ablation procedure to get rid of atrial fibrillation in paroxysmal atrial fibrillation. So 80% after 1.5 procedures and only half of the patients after one procedure. And this is very important for the patients. Otherwise, if the expectations are that high, you will lose your patients, and the patients will say they do not know anything about medicine. I don't trust you anymore. So this is a very, very important aspect, that the patient knows that it can come to a recurrence. Yeah, that's what I said. And if you look on the long term, one procedure, only 30% after 10 years. Just think about 10 years. We have now the year 2021. We started on a routine base with catheter ablation, PVI, maybe 2008. So there are not too many long-time follow-up data. And in this study, this is one of the studies of my old hospital, after 10 years, 60 to 70% stable sinus rhythm. And I think this is a pretty good result with, don't forget, and I said long-term follow-up, 10 years, with old technologies. These patients were not treated with the newest generations of balloons or with the newest generations of 3D mapping systems. These are old generations and less experienced operators. You heard about it. Why do we talk about recurrence of AF? Very quickly. So you see here, this is again a left atrium from behind. This is the septal pulmonary vein. What we do? What do we do? We mark the ostia, just for example, and then we give current, radio frequency current, and we make a line around the pulmonary veins. We isolate, and then we do it on the other side. And maybe after 2 hours, the PVs are isolated. But where is the problem? Why don't you have, just for example, every 10 kilometer between Coimbatore and Chennai, 100 EP labs? This is not too easy to do. There are a lot of limitations. These are very complex procedures. Just think where the heart is. The heart is behind the lung. If we breathe, our patients breathe. They are not, we don't do the procedures in apnea. They breathe. So the catheter will move also with the lung and with the heart. And if the catheter moves, you don't have a nice catheter tissue contact. If you don't have a nice catheter tissue contact, you won't get a nice necrosis, a transmural lesion. And what happens? Somewhere here maybe, the tissue recovers. And if the tissue recovers, the patient gets a recurrence. This is why we are talking about 80%, one of the reasons. It's a long learning curve. You need good operators who knows how to do. And that's what I said, it's sometimes very challenging to create good transmural contiguous permanent lesions. It does not make sense to operate here, 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 here. That's why the EP world was seeking for a single shot, I would say single shot device which is much more easy to handle. And this is, just for example, the cryoballoon. The procedure is basically the same. You start from the groin, a venous puncture, nothing complicated. You puncture the groin, you have one diagnostic catheter in the coronary sinus, you go up with a long sheath, do the transeptal puncture. So it's the same like before. But now, you don't have to do for many hours the 3D map. You see here, what is this? This is the balloon which comes out of into the left atrium, and these are the pulmonary veins, and you have here a spiral catheter. With this spiral catheters, you can see the potentials of the pulmonary veins. And once these, I show you later, once these potentials disappear, you know the vein is isolated, and I did my job, I'm done. And the patient, he will feel good. So, you target these pulmonary veins with these achieve catheter or spiral catheter. You inflate the balloon, and the next step is very easy. You just push the balloon against the antrum ostium of the pulmonary veins. You give contrast medium, and if the contrast stays there, you know you have a perfect occlusion, and then you are almost done. Just hold it there and start freezing. Just cool down, and you will get temperatures below 40 degrees. Below 60, it's recommended to stop because one might induce collateral damages, but between 40 and 60 degrees, you will have a good result, and the PVs are isolated. And you have to do this 4 times for the left superior, left inferior, right superior, right inferior, and then you are done. And I think one might imagine that this is much more faster than doing a 3D map and visualization and ablation. This is similar to a simple coronary angio. Maybe a bit, yeah. Okay, good. Good. So basically, what happens with the tissue? What happens with the tissue? If you compare cryo lesions to RF lesions. I don't want to go too deep into that, But what you see at the end of the day, that cryo preserve the extracellular matrix, and it does not denature the proteins. So with other words, after RF ablation, sometimes you see thrombus formation, which you do not see after cryoablation. It's more homogeneous. So everything what we tell the patient, this is a more soft and a soft operation, we see also on a cellular base. What about this is something, the data are old, but nothing changed on that. This is something your patient wants to know. What is the acute success? This is something the patient will also ask you. I go with AF to the hospital. Do I have AF the next day? No, because acute success is almost 100%. So it is very, very, very rare that you do not isolate the 4 PVs, or that you have to stop a procedure, or that you won't succeed. So acute success rates are very, very high. You heard already about this trial. I will do it very, very quick and short. This is the largest ablation study which has been ever performed all over the world. This is the Fire and Ice study, which gives us basically the evidence to do this. And this study compared 1-to-1 cryo versus RF ablation, and I do it very short now. It was a 1-to-1 randomization with 700 patients, and the outcome was, yeah, what was the outcome? Okay. That's interesting. There's no difference between the gold standard radiofrequency ablation. At that time, you just have to think there have been millions of ablations with radiofrequency and not that many ablations with cryoballoon. So there's no difference. Both are equal. And this study was never powered for superiority, only for non-inferiority. Everybody, so if this study would have been powered in a different way, the results might have been different. What about the safety endpoint? And this is something, so what your patients will ask. What about stroke after procedure? We are performing ablation within the left atrium. There's a connection to the head. Stroke risk intraposteriorly, very low. Of course, there's a risk for groin hematoma, of course. What about all-cause death? All these complications, very, very low. So at the end of the day, when is the best timing? We had to do either radiofrequency or to treat, I would say, to perform a rate control treatment in the patients. When is the best timing? We heard about that in the previous trial. There's a progression from paroxysmal atrial fibrillation to persistent, to long-standing persistent, to permanent AF. And if we keep all these things in mind, in very clear cases, I would say as early as possible. In Latin, we would say in dubio pro reo, just for the patient. This is a study which has been published in the New England Journal at the end of last year, 2020. And this study is the biggest study on this topic, and this exactly analyzed this fact. It analyzed the usual care in AF patients, rate control versus early rhythm control, either amiodarone, flecainide, or catheter ablation. And what we see is that outcome in rhythm control is much better, or is definitely better than in usual control, concerning cardiovascular morbidities, complications, mortality. This is something else we have to talk about if we talk about cryoablation. has been published in the New England Journal of Medicine this year. And then I'm almost done. I can see that you're hungry. Okay, as initial therapy for patients with atrial fibrillation. This was a randomized trial, 200 patients, 1-to-1. Antiarrhythmic therapy versus catheter ablation. So we are back to your question. You have a patient with paroxysmal atrial fibrillation, 45 years old, first diagnosis. He never had flecainide, he never had amiodarone. What to do? Catheter ablation or drugs? I said amiodarone is poison, but if there are no other drugs, maybe amiodarone is not poison. So what to do? This was the question in this study. And this was indeed a very nice study. And this is the outcome. As you can see, cryoballoon was a long-term follow-up, 1 year, much more successful than antiarrhythmic therapy, 75 versus 45%. And these patients had event recorder, loop recorder implanted. So this is not the very weak Holter or 12-lead ECG follow-up. This was a good follow-up, standardized follow-up. This is also a question which would be interesting for every one of your patients. And also, if I'm a patient, I would be also interested. Because the patient, if he goes to a doctor, how can the patient know this doctor is good, he's medium, he's average, he's excellent? He cannot know. So, with other words, the patient would have a double benefit if the technology is that easy that results are reproducible, good, and not dependent on the excellence of an operator. So let's have a look. There are some interesting, I do this also slowly. There are some interesting studies which analyze this. Are the results reproducible? These are data from France. Couple of centers in France, and they do RF ablation, cryoballoon ablation. Every color stands for a different institution, and as you see, the ratio is different in every institution. And what you see, some institutions did more cryo, some institutions did more RF. And if you look to the left side, these are the cryo data, outcome data, and these are the RF outcome data. And here you see that the outcome in all the centers were completely different. And here it was pretty much the same in the cryo group. So, a short learning curve, reproducible clinical outcomes. There has been very recently, a couple of weeks ago, also another publication. I'm sorry, I was on the flight. I had no time to put that slide also here. But they analyzed really how many ablations a center performs and the outcome data. And there was, after cryo, it showed it basically was the same. There was no difference between both groups. So, from my side, ladies and gentlemen, take-home message. PVI, and this is something really new, is a class 1 indication right now. Okay. Catheter ablation for patients with atrial fibrillations. We have much more evidence right now that early ablation, RF and cryoballoon, ablation therapy is something positive for the patient. We have to stop progression from paroxysmal to persistent AF. This is something very important. We have, with the easy technology, we have similar outcome data after cryoballoon-based ablation procedures in less experienced centers or by less experienced operators. But this does not mean unexperienced. There's a difference between unexperienced and less experienced. You need a certain level of experience, of course. You need to be an electrophysiologist. Otherwise, it does not make any sense. So, I think I have my 30 minutes. I could talk 1 more hour. I think I would stop at that point and would say thank you very much. Thank you. Open for questions.